Well, it goes without saying that this is a gripping meeting, and you just did it brilliantly, Julianne and Hillary, having parents, and researchers, and clinicians sort of alternating and intercalating between each other. I had the opportunity to speak here last year, and I was asked to give an update, so I'm not promising a earth-shattering research sort of heavy scientific presentation as we heard from Xenon and UVA and Michigan. It's fantastic. I just thought I'd give an update from last year. So here goes. Let's see. And I didn't turn it off. Good. This reminds me that in my 25 plus years now, actually, of practicing child neurology, one of the most palpable changes has been going to meetings like this of these specific genes. The SCN8A meetings, there's an SCN8A meeting coming up in July. I recently came back from a KCNQ2 meeting in Silver Spring, Maryland. Last year in Boston, we held an SSADH meeting. This year, we're hosting an AHC meeting, which is ATP 1A2 and 1A3. It's like an alphabet soup, but it's pretty evident that we need to get these groups together and have a universal approach than having these smaller meetings that are splitting up the resources and efforts. I think that if there's anything that comes from this, I hope it's that. I just thought I'd sort of introduce the 8A concept to those who are less, knowledgeable about this scientifically by pointing out that we've all heard so much about SCN8A. There was a time that people blamed the pertussis vaccine for causing severe epilepsy, and the U.S. government paid lots and lots of dollars to folks who had pertussis vaccine encephalopathy, till we found out that most of those cases were actually SCN8A mutations. And there are many, many mutations of that gene. And then SCN8A became known, and that has several different phenotypes. So, you have one gene, and you can have these different sorts of clinical presentations: a benign familial neonatal infantile seizure syndrome versus the generalized or genetic epilepsies with febrile seizures versus Dravet-like disorders, Ohtahara, et cetera, et cetera. 9A is emerging as an important sodium channel, as a sort of a susceptibility gene. And of course, our focus is 8A. So last year I had presented this one infant. Is the family here? Not this family. So I presented this case because it was so interesting that this little child presented at 5 months of age with spells that were misdiagnosed as Sandifer syndrome, reflux-related symptoms. And it really wasn't recognized until 11 months of age that these were infantile spasms. And it's just something to look out for. And the child went on levetiracetam, Keppra, right, because they would seem focal in some ways and did not do well at all. Went on clobazam, phenobarb, vitamin B6, folinic acid. And I thought I'd show some video EEG of our patients because we've had great talks.
We haven't actually seen some of the seizures. So here is the episode. See the stiffening episode associated with rhythmic slowing in sort of a lot of the channels of the page. And then the arms relax. And this was the spasm. And it clustered. It happened again and again.
Yes, let me see what happens on the next. Can you turn on that video as well? Oops. This one.
So the video is dark, but it's the same stiffening of the arms, and the EEG is showing that same rhythmic slow wave pattern during the spasm. But the EEG between the spasms did not show this high voltage chaotic pattern we call hypsarrhythmia, so this was missed.
These infantile spasms, most clinicians associate spasms with an EEG that shows hypsarrhythmia, but the EEG background was actually pretty unremarkable, and that's why this was missed for months and months. So SCN8A is a very tricky diagnosis for a clinician. So what I thought I'd do this year is show you the series we have at Boston Children's of our SCN8A. I think we have 8. And there's too much detail for an after-dinner talk, but I do have a summary at the end. But I organized our patients based on their age of onset. So you see on the left, we have a newborn who actually wasn't diagnosed until 9 years of age. He's currently 11 years of age. But I wanted to point out that seizures were initially neonatal seizures, just undiagnosed for years. And the child had a lot of status epilepticus. And notice I wrote CPR times 3, so the child coded 3 different times. Clearly a risk factor for SUDEP. The treatment included a pacemaker. But Dr. Harris gave this wonderful talk just a few minutes ago, and I think she's right. We have to think about cardiac arrhythmia, consultations, and pacemakers in these patients. The child's been treated with phenobarb, lamotrigine, valproate, levetiracetam, clobazam, topiramate, but currently is nonverbal and non-ambulatory. And I went through all of our patients, and I just wanted to point out that one, lots of things on all these. A couple presented at 3 weeks of age. Those are twins. Then a 7-week of age. The current ages, though, are interesting. The 3-year-olds, a 13-year-old. 13-year-old has a moderate intellectual disability, not too bad. And here's the other 4 presenting at anywhere from 2 to 14 months of age, currently between 22 months and 15 years of age. That last one, these mutations are different from each other. It's been seizure-free for a couple of years, has a normal IQ, so clearly there's a wide spectrum. And like with any other disease, we always start with the most severe, and then we learn there are more and more out there with different variants that are not as severe. We also have several patients who have SCN8A variants of unknown significance that might be causing epilepsy, but we're not sure yet. I did not include them. I just included the ones where we really think it's very clear that these are SCN8A epileptic encephalopathies or related epilepsy. So here's a summary. The onset was anywhere from newborn to 14 months of age, but median at 2 months. They were diagnosed anywhere from 1 to 14 years, but the median was 2.5. The current ages are 22 months to 15 years. Seizure types have been neonatal, infantile spasms, tonic-clonic, myoclonic, focal, and status. Lots of medications, ketogenic diet, endotracheal tube intubation, pacemaker have all been used. And the outcomes of our 8 patients, 5 are nonverbal, 2 have intellectual disability, and 1 just learning disabilities with a normal IQ. So that's our series. And I wanted to finish because one of our patients, and her mom is back there waving her hand, she made the press. This was a Boston Children's Hospital newsletter this month, and she's just become a favorite. Is there a pointer on this? Huh? Oh. Anyway, there she is in the middle with all the nurses and the nursing staff. So that's our series. We've got 8 patients, and maybe we can get a clinical trial going with some of these promising therapies. So thank you very much.